It's wonderful to be here. Thank you for inviting me. I spent 19 years at the University of Texas at Austin, so it's great to be back in Texas for a few days and a lot of familiar sights here. Today I'm going to talk to you about this amazing study that I'm fortunate to be a part of at this point in my career. The AdHealth study, or more formally, the National Longitudinal Study of Adolescent to Adult Health. So the U.S. does not have a birth cohort study, a nationally representative birth cohort study. AdHealth is one of those that's perhaps closest to that endeavor. It's a cohort study that's been following a nationally representative set of individuals for close to 30 years. The data are available to you all, and I really would like to make the data more widely known, and hopefully more and more students and faculty will use the data. We collect it for the scientific community. It's not ours at UNC's, it's all of ours. So this is truly a kind of community scientific endeavor here. So this is what I'll be talking about today. Where did it come from? Where are we at now? What are some of the opportunities for the future? So a little bit about the evolution. AdHealth was developed in 1993 by a congressional mandate. Congress said we need to know more about the health of adolescents in our country. This was in the era of HIV and AIDS was really taking off, and we knew very little as a country about adolescents, about their sexual behavior, about their drug use, and so forth. So UNC got the grant then. It was originally going to be a two-wave study, just adolescents ages 7th through 12th grades. It's going to be 1 year apart, two-wave survey. It was going to be done. But the PIs of the study then said, hey, we can make this into something more. And they applied for more funding. They then began to follow people as they moved into adulthood, and then and we've continued to do that. So it was renamed, added 2 adults in as the cohort got older. In 2016, Congress gave the Golden Goose Award to the AdHealth study as one of the scientific studies that lays the golden scientific eggs. And so that was a real honor at the time. I had nothing to do with it, having not being involved in the study until just a few years ago. But most recently, what I talked to you about today is that Wave 6, the 6th wave of data collection, was funded by the National Institute on Aging. Keep that in mind, that these folks were adolescents in the mid-1990s. They're now in their 40s. So aging is not just the study of old people. Aging is the study of the process of moving through the life course and kind of what happens as people do that, and 5 co-funders. So I'll talk to you today a lot about the Wave 6 study that's ongoing. Okay, a little bit more background though. So AdHealth is really unique study compared to many studies of health and aging in our country. We've got prospective data since adolescence, all of the questionnaires and contextual data and a lot more. We've got biomarker, anthropometric and other biological data and cognitive data before many health outcomes manifest. So you can kind of look under the skin and kind of see what's going on within the body before disease manifests. We've got very rich data from multiple levels, cellular levels, but also individual survey and contextual data. AdHealth was a school-based design from the get-go. So it was individuals nested within families and schools. So there's a lot, we know about what schools people went to, the characteristics of those schools, the neighborhoods in which people lived in. We've continued to collect contextual data along the way. So you'll see some of that with Wave 6. We've got parents' data from adolescents from when AdHealth cohort were kids, and we've continued to collect parents' data as well. I won't focus on that today, but I'll show you just a little bit in the design. A lot of people who analyze AdHealth data focus on health disparities. There were oversamples of Black, Hispanic, and Asian students back from the get-go, which was really quite unique at the time. So many studies of health disparities. And it's nationally representative. When the data are weighted, as we recommend in user guides, they tell the American story, at least of this particular cohort who is moving through time. Okay, so leading into Wave 6 then, so people were in their 30s, and one of my, I moved to UNC, and my challenge was to take AdHealth from a study of adolescents and young adults make it into an aging study with new funders. And so the ideas here is that, unfortunately, this is not a healthy cohort. of individuals, and this is nationally representative. So obesity levels in this cohort are 47% in people in their early 40s. Cognitive and physical functioning is not great when you look at some of the data. Mental health there's a lot of suicide ideation. We've had a lot of suicide deaths in the cohort. Behavioral health, a lot of drug use, heavy alcohol use, and so forth, and high rates of mortality among young adults and midlife adults in our country, of course. So part of the rationale for continuing this cohort is as they're moving into early midlife and beyond, this is a really important cohort to continue to study. There's also wide, and in some cases even widening health disparities by socioeconomic status, by race, by gender, by sexual orientation. And so we've got a lot of data on not just race and sex and so forth, but for example, skin tone and sexual orientation, gender identity, and so forth. And those questions were always evolving as we collect new data. And so we laid out a case for the need for the continued longitudinal data collection here, multi-level, not just individuals, but individuals nested within multiple layers of context. And it's because it's nationally representative sample as well that can tell the story for the nation as a whole. So our goal for the Wave 6 study was simply to collect and disseminate data. We don't have any hypothesis testing in this. This is it's called a U01 mechanism from the National Institute on Aging. It's a cooperative agreement from the National Institute on Aging. I'm the PI, but we work very closely together with NIA, and we want to collect these data. We want to get them out to you. And so I might write a paper or two, but really this is for the scientific community. We want to collect and disseminate these data. We want to protect our participants, and the data is going to be focused on the life course determinants and trajectories of health, cognition, health behavior, and health disparities among this large and nationally representative cohort. Since we were originally funded in 2021, we've added 2 supplements focused on the exposome. We're adding a lot of data on pollution, noise, lead, these kind of issues, and then we added a retention supplement as well, trying to elevate our response rates to as high as possible. Okay, this is a busy slide, but let me mention it. So this slide lays out the longitudinal design of AdHealth. Each row is a wave of data collection. Okay, starting with wave 1 at the top row and down to wave 6, where I've drawn the little red circle or oblong along wave 6 there. So if you want to focus at the bottom for just a moment, that would be great. So that's the data we're currently collecting over these 3 years, 2022 through 2024. We're collecting birth and death records. I should put in there as well, we're collecting college transcripts right now as well. Almost everybody's done with college, so we're going to know a lot about what schools they attended. And so we've got high school transcripts, but now we're adding college transcripts as well. In the middle, we got the survey administration. That's kind of the bread and butter, is the survey. We got a 90-minute survey instrument this time. I'll share with you some of the content in a few minutes. These people are 39 to 49. It looks like the average age is going to be 44 once we're done with the data collection. Our goal is to collect 13,000 respondents out of the original 20,000 or so. So 30 years later, that's a pretty good retention rate. If we can get to that 13,000, I'm optimistic we can. We're also have a separate parent study where we're going back to a subset of the parents, oversampled for Black and Hispanic parents of the cohort members. So we'll have 2 generations of the same cognitive data, of genomic data, of social survey data among those 2 generations. So those data are coming down the road as well. And then we also do, on the far right bottom, we do a home exam for anybody who consents to do that. So we collect blood, medication data, blood pressure, and so forth. So there's a nice set of biological data as well that corresponds with the social survey data. So kind of that's right at the top, I didn't know where to put this in the slide, but each wave also includes contextual data. So we know where people live and we have their coordinates, and so we can layer onto them then the contextual data from their neighborhoods, from their cities, from their counties, from their states, and so on. Treasure trove of data as this cohort is moving through time. Okay, and we also argued for Wave 6 that AdHealth is best suited to explore cognition as well. we're really, again, these people are in their 40s, but we're really worried about cognition given the really heavy drug use and alcohol use among this cohort, really high rates of obesity and early cardiometabolic disease as well that play into the long-term cognitive functioning of this cohort. So we know a lot about cognitive functioning, cognitive decline in older adulthood. At the national level, we know much less about people when they're in their 30s and 40s and 50s. So our endeavor here is to fill in the gap for the collection of cognitive data. I'll share a little bit about that as well, the kinds of things that we're collecting. Okay, so in short, during wave 6 here, we're going to re-interview as many cohort members as we can find. Again, it's the same people that we're following from wave 1 in the 1990s to now, okay? We never give up on them. Even if they hadn't answered our surveys for 20 years, we try to find them and survey them. We're collecting this in-depth cognitive data on their cohort members, and we're doing so both in the web survey and in person. We got a really innovative, we think, web plugin to collect cognitive data as well on the web, and in person we're going to be able to compare those cognitive assessments across those modes to see how that works. We're revisiting cohorts for this health exam. We're conducting mortality surveillance, so when people die, we have 2 MDs that review the deaths and get the medical records and so forth to best establish cause of death. We're building contextual data files. We've got literally thousands of contextual variables available for analysts, conducting key assays to get those out. Or we've also got stored blood specimens as well in our lab that people can write proposals to us to use those specimens for ancillary studies. And then we clean and protect and disseminate these data for the scientific community. I'll talk about how to get a hold of the data at the end of the talk. Okay, so for wave 6, a little bit getting into the weeds here. One of the things my team and I decided to do this time is split the sample up into 2 samples, innovatively called sample 1 and sample 2. It's not very innovative, but it's okay. So sample 1 is on the left, sample 2 is on the right. The big difference here is that sample 1 is largely a web-based survey. It's cheap, okay? So we try to collect as much low-cost data as we can on the left side, followed up by, it's in small type, but on the web, that we also do non-response follow-up called NRFU for short. And so the web data, you'll see that there's much higher response rates among females compared to males, among highly educated compared to low educated and so forth. So we use NRFU to try to fill in the gaps on the left side to better balance out the sample. On the right side, sample 2 is all in-person data collection. So this is much more expensive because we're knocking on doors in Wyoming and New York City and Alaska and Hawaii and everywhere. And so we've got a nationally representative subsample of nationally representative AdHealth in sample 2. I don't know if you can see it, the number up there is about, between the pilot and the full sample 2, it's about 4,000 individuals. We're aiming to get about 3,000 total for sample 2. It's about 1,000 Black, 1,000 Asian, 1,000 Hispanic, and 1,000 white individuals purposely selected into sample 2 so that there can be a lot of disparities work in sample 2 separately. Most people will merge sample 1 and 2 together because the survey is common across the samples, okay? So I'm gonna focus a lot today on sample 1, the pilot web survey, the full web survey, kind of where we are, and then I'll touch on sample 2 a little bit later, so as well. Okay, so how are we doing with sample 1 web data? We've got about 15,000 people who we've issued invitations to participate in the web survey. We send them a link. Here's your link. Here's your passcode to go on, and we remind them. Every few weeks, we send them another reminder. Can you please log on, take the survey, you're part of the AdHealth cohort, and so forth. As of 2 days ago, we had over 7,000 responses so far. Our goal is to get to 8,800, so we're getting there. And it's just, again, reminder after reminder after reminder with RTI International doing our field work. So we're at 46.1% right now. We want to get to 58% with the web survey. Again, this is much more cost-effective data collection compared to in person. So how are we going to get from 46 to 58? Well, we've got what are known as break-off cases, people who started the survey and didn't finish. And one of the early questions we asked them is, hey, can we text you if you, for future? So they've given us consented. So we're texting them, say, hey, could you log on and finish? Okay, so we're constantly doing that. We've got another reminder going out this week. And then we've got 3 boost incentive reminders going out holiday time, okay, to try to increase. And so the boost incentive adds a little bit more to their incentive to complete the data collection. And then if approved by the IRB, we'll continue to offer the boost incentive into next year and issuing continued reminders so that we can get up to that 58%. It's really important for us to do that because we not only want a high N for people, but when you start to do subgroup analysis, it's really important to build the sample size as high as possible. Okay, I mentioned, web surveys are not, you don't get equal response rates across groups. So by biological sex, females, much higher response rate than males. By race, ethnicity, white participants, much higher than other groups. So this is the first, like I said, 7,000 or so cases to date. And then by educational attainment, it's people like us more likely to answer these surveys than people who are lesser educated. Not a surprise, we know this from web surveys. That said, it's still very good for us to do this because you can complete these surveys much lower cost than in person. Okay, I'll get to in a minute how we're going to fill in the web survey with NERFU. Okay, so keep that thought in mind. But I'll show you a little bit of teaser data here because these are the kind of data you might be able to expect when we disseminate in 2 years. The average age right now, 43.2. As time goes on, will inch up closer to 44 will be the Wave 6 data. The kind of things we added in Wave 6, again, this is a longitudinal study, so we have a lot of common things that we keep asking from wave to wave, but we've also added a lot of new content as well because the cohort is they're no longer kids, they're in their 40s and so forth. So we added a lot of questions on race and self-reported skin tone, for example. Race composition of people in the household, for example. We've got interviewer reported skin tone back from earlier waves. Now we get self-assessed skin tone. We've added more race categories for people to better self-respond and so on. We've had a lot of discrimination questions. We consulted with David Williams, one of the leaders in this area who gave us a lot of good ideas about discrimination. We've added a battery on chronic and anticipatory stresses as well. Work-life balance, everybody feels that, people in their 40s especially, and caregiving, those things maybe go together. We think of this age group as being pulled and tugged in every direction possible. Kids and parents and jobs and another jobs and nighttime work and so forth. So we've got questions added this time about caregiving as well. We've added a battery on trust in institutions, kind of given kind of what we're seeing out. I'll show you a little piece of data on trust in science in a moment. Enhanced health behavior measures, we had a little bit there as well on what are those things called? E-cigarettes, yeah. Enhanced mental health, we always have had the CESD, but we've added another battery on mental health as well. We added some physical health measures, including COVID-19 and pain measures, and then we've added a lot of survey questions as well as these kind of plug-in batteries as well on cognition. Let's show just a little bit of data, but this is a standard self-rated health question. The only reason why I put this up is, okay, keep this in mind, these are unweighted data. These are the first 7,000 or so respondents. Take them with a grain of salt. It's kind of who answered the survey first, okay? But roughly 17% of the cohort are saying they're in fair or poor health. Okay, these are people in their early 40s on average. So that's probably not very good. COVID-19, about 60% of people are saying that they've had COVID at this point. And then we're also assaying the blood for COVID, and we're getting we assayed the first 2,000 so far, 60%. Now, whether or not those align with one another, we'll see. But both indications are about 60% of the cohort has had COVID thus far. Chronic pain, 32% this isn't just pain for one day or something, but chronic pain, very high level of chronic pain. Menstruation, about 25% of females have either are postmenopausal or perimenopausal. So as they're moving through time here, this will be very interesting for us to kind of continue to follow the cohort as well. The bars look small here, but taking care of a parent almost every day, 12% are saying either very true or somewhat true. So 1/8 of the cohort, more female than male. But again, when you think about the pulls and tugs of early midlife, this is a lot of people who are doing this work. A sense of purpose, you can add up the low bars on the left, and so a lot of people saying it's absolutely untrue that they have a sense of purpose in life. So something like 15% of the sample are saying, no sense of purpose at all. But on the other hand, a lot of people are saying absolutely true there too. Trust in scientific community, we get trust in a large range of institutions. I don't show you the Congress one here because it's kind of embarrassing, but in terms of trust in the scientific community, about half the cohort of people who answered so far say trust, but another half saying either or no. Okay, so, and these are people who answered at health, okay, and they're highly educated, more female, more white. So this is something to keep an eye on as well. We're very interested in looking and see how measures of trust correlate with health behavior and health status. Opiate drug use, basically, have you ever used opioids kind of more so than what was prescribed to you or from the street or so forth? About 9% saying yes. Again, this is not a weighted sample, so this is only going to go up when we kind of collect more data and weight the sample. So a lot of people here as well. Gun ownership, something I added, given U.S. society as a whole, personal experience with family members and so forth, 43% saying that there's guns in their home. And we have another question about most of them are saying that they personally own guns, and some not. Here's the 4 measures of what we call the Test My Brain Cognitive Test Battery. This comes from a Harvard spin-off company. Laura Germain at Harvard has put these together. You can actually go online and take these cognitive tests. Through consultants, we've selected 4 of these. Take about 15 minutes of survey time. The participants can't really tell that they're entering to this kind of plug-in web device that does this, but the 4 tests that we selected in consultation with our consultants were the verbal paired associates, which is a verbal memory kind of test, digit symbol matching, which is processing speed, gradual onset is executive functioning, and then backward digit span is short-term memory. These things are hard. They're very humbling to take these, but again, you can go online. One of the cool things about these as well is that they've got these volunteer samples who take these, and so we can compare our data to the volunteers that have taken them and look by education. I'll show you here in a minute to compare how do our data look in comparison to the volunteer samples, at least that from the Many Brains Project, it's called, that has been collected. So I'll show you just one of them here. Close to 90% of people are completing these cognitive exercises. I didn't put this on the slide, so most people are doing this. But interestingly, for those who don't complete, we have a lot of data on them going back to their high school years, as well. So who even starts these, who completes these? You can do selection models, like who does this stuff. So in terms of this backward digit span measure, which is this kind of short-term memory, what it does is say, here's a number 532, and then a few seconds later, you got to repeat it back to the computer 235. I think that's right. And then there's 4 digits, then there's 5 digits, and so forth. And so, how many digits can you successfully repeat backwards to the device? Okay. And so, on average, on the far left, it's about 5 digits that people are successfully able to repeat back. And you can imagine, with a telephone number, how hard that might be to repeat backwards. So I couldn't do that. So overall, our So far, we're at 5.2. The normative score, which is volunteers, is 5.6, so we're close to that. And then we stratify by education level here. You can see that both for the Ad Health cohort and for the volunteers at the Many Brains Project, you see the gradient as you'd expect. Higher education is associated with higher scores here with this. And we're very close as well to the normative scores that are recorded by the Many Brains Project. So this is some evidence that we're at least in the ballpark. NIA is really interested in us doing this because they really want to know for the national level as a whole, can you collect decent cognitive data on the web? And early indications are that most people are answering the stuff and the scores look pretty good in the kinds of ways you might expect. So, okay, that's just a little bit of teaser data. Again, I don't want to show too much because at the same time, who's the first 7,000 people, Okay, so sample one NERFU, again, we want to fill in the data here. And so that's this little part here. A lot of people take sample one on the web. We want to be able to complete out this side of Ad Health, this sample one. But here we're going to be knocking on doors saying, can you please take the Ad Health, you're in the Ad Health studies. Oh yeah, forgot to do that, and you do that. So our goals here is that we want to increase the response rate, from based not only just on the web, but get us closer to a 70% overall response rate. Reduce bias in estimates, better estimates. We want to increase the racial and ethnic diversity because you saw lower response rates among racial and ethnic minority groups compared to whites in the web. We want to increase educational diversity and increase representation of males in sample one. And our field work for this will start in February. We're continuing to do web, and then finally we'll kind of go to the field in NERFU together with sample two. So our field interviewers will be doing both NERFU, which mimics sample one, and then sample two I'll talk about in a minute, all over the country. So we've got about 100 field interviewers we're hiring right now. Okay, so how are we going to do this NERFU? Said, okay, this is, we did a simulation study because it's not as easy as it seems because we're sampling non-respondents. Okay, by definition, that's a NERFU, is non-response follow-up. And we can't go knock on all 7,000 non-respondent doors, but we want to sample and get the kind of right people, if you will, in order to fill in the sample. So we did the simulation study. How can you do this to reduce bias in estimates, but to get low-educated, male, minority sample members? And what would be the best way to do this to both reduce bias and increase diversity at the same time, which is not easy because we oversampled minorities from the get-go. So there's sample weighting issues at the same time. Minority group members tend to have lower sample weights in Ad Health. So if you just do NERFU going after the high weight people, then you don't accomplish these goals together. It's a statistical kind of thing. So what our simulation study showed is that we need to sample about 3,500 of the 7,000 non-respondents in order to get 1,200 NERFU completes. Okay. We chose a reserve sample as well in case we need more. We're going to include everyone who's less than a high school degree because remember the web response rates are really low for those with less than a high school degree. And we're going to oversample Black, Hispanic, and Asian sample members by something, it's called a probability proportion of size, proportion to their survey weights. We elevate the survey weights by 10, and so we really are going after those who have both high survey weights, largely white participants, and minority group members who wouldn't be in the NERFU sample, but we need them to be in order to diversify this sample. So this is something that's very kind of strategic that we developed in consultation with our folks at RTI International. So we'll start this in February. So we think it will accomplish our goals because we don't have the money to go after all non-respondents. Really expensive to do. Okay, so of the 3,500 people sampled in the NERFU, this is what they look like demographically. So about 38% white compared to about our cohort is like 65% white. So much lower white because, again, those people who completed the survey were high response rate whites. And then about 33% of the NERFU sample is black, 19% Hispanic. So a lot of over-representation of selection into the sample in order to best fill out the sample one. I don't show you the male, or more males in the NERFU sample, much more low-educated people as well. So we're going to be spending money to in the in-person fieldwork to best diversify the sample. Okay, shifting to sample 2 from it. Remember on the diagram, the right side, all in-person fieldwork starts in February as well. So this is all in person. It includes the same survey as sample 1, but then an additional 35 minutes or so of cognitive, sensory, and physical functioning tests. Things like grip strength, olfactory, and more cognitive batteries as well. It's about 4,000 people selected in sample 2, all in-person fieldwork, equal Black, Hispanic, Asian, and white. And our goal is a 73% response rate, so close to 3,000 respondents in sample 2, that people like you and I could analyze this separately as a standalone nationally representative sample or in combination with sample 1. Okay, we did the sample 2 pilot so far. We selected 2 sites, we're 2 cities, to make sure that this field work will actually work, how long will it take, can our field interviewers get the job done, and so forth. So there were 262 people in these two cities in Ad Health, and we had 75 days to do as much as we could. Very quick field work. So we hired 8 FIs in these 2 places. We identified these 262 people. We implemented the training, the data delivery, and so forth. And we did this field work in 75 days, far shorter than the 9 months of field work that will occur in 2024. So we said, okay, we need to do as much pilot data work as quickly as possible to see if our protocols are working. We did well. This just finished up about 2 weeks ago. We completed 145 interviews in just 75 days, 55%. Our goal is 73% for 9 months for the nationwide. So this trajectory was really quite good. We're very pleased with this. We didn't think we'd get this many. Over 90% consented for the home exam because this is in-person fieldwork, but then we asked them, can we come to your home with a phlebotomist to take your blood and so forth? 90% said yes to that. The highest response rates in person were among Hispanic and Black sample members. Okay, remember on the web, it was the exact opposite. Okay, similar response rates by educational attainment and biological sex. Okay, and despite a very difficult protocol, the quality of data appears to be very good. I'll show you 1 or 2 survey items here in a moment. Okay, here's the response rates in this, again, in this 2-city early pilot. 56% for female, 54% for male. By race ethnicity, you see the response rate there, the highest for Hispanic and Black participants in these 2 places. And then pretty equal across educational attainment categories as well. So again, web survey is very different than in-person. That's why we're using in-person NERFU on the website. But the web is good because it's cheap. You can collect a lot of data for low cost. I'll show you 1 item here from this pilot, 145 cases. This is the olfactory test. This is so fun. It's like a scratch and sniff test, and people get 12 of these, and you literally have a pencil and scratch off. Is this banana? Is this cinnamon? Is this motor oil? And you see how many people get this right. And the average here overall is 9 out of the 12. So 12 is the highest possible score, and you can see how it differs by education in this pilot. The lowest scores among those with a high school GED or less. One of the hypotheses here is this could be associated with smoking, could be associated with cognition as well. It's hard to know without actually doing the analysis. But based from what we read on this test, scores of lower than 8 are pretty worrisome in terms. I remember when my dad got dementia and eventually died. That was one of the first things. I can't smell anything. I can't taste this food. What is this stuff? And it was, this was kind of an early indicator that something was going astray here. And so this longitudinally will hopefully get at that kind of trajectory. So just a little bit of teaser data here as well for sample 2. Like I said, we're also doing grip strength. We're doing lots of other cognitive tests from the NIH toolbox to collect cognitive data. And then we did hearing and vision tests as well in this that unfortunately we have to cut because we'll talk here about the challenges in person. Okay, what we tried to do here involved a lot of devices. All of these tests have different devices. This one needs an iPad, this one needs an Android, and so forth. And so literally our FIs were going into people's homes with a big Pullman suitcase that we had to buy for them with all these devices. So it's expensive, and it took 3 hours on average. Some of them took longer. So this was far longer than what we planned or budgeted for, given the complexity of these tests. These people are in their 40s. They got kids and dogs and parents and jobs and multiple jobs and so forth. They can't do 3 hours with us. They were like, get out of our house, So, and then the data that we're getting were really complex too. All these data uploads. So a lot of good news on this. We can do it. We can collect some great data. We had to make some cuts. So as we move to the full sample 2 in February nationwide, I'll share with you a little bit of strategy of what we're doing. So we're going to do longer training with our field staff. We're flying all the field workers into RTI Internationals right down the road from UNC. And we're going to do a 5-day. It's not long enough, but it's better than a 3-day training period. We'll be hiring, again, close to 100 FIs to cover most of the country. And then for areas we can't cover, we'll be flying FIs to other places, to rural areas and so forth to do that. And our field period will be at least 9 months, and we may even go into 2025 in order to achieve our sample size. Okay, in order to make some cuts, 3 hours too much, we needed to get down to 2 or so. So we're switching from a computer-assisted personal interview to a computer-assisted self-interview. We're basically walking in the house, talking through consent and saying, here's the laptop, take the survey. When you're done with that, then we'll do all the exercises and the grips and the smelling and that kind of stuff. That's going to save us 30 minutes. So it's not the mode we wanted to go with. We wanted to go with this, the personal interview where the FI read the questions and so forth, but we had to give that up, and we can save 30 minutes there. And then we had to cut the vision and hearing tests. Vision, there was almost no variation in the pilot. People, once they got their contacts or glasses on at these ages, people were pretty good. There was variation in the hearing tests, but it took 10 minutes, and we had to give that up this time. It was the hardest decision we had to make so far to give that up, but we hope to add that next time if we can cut other things. Okay, this is all the survey part. Remember, sample 1, sample 2, the cognition and so forth. We also asked people then, can we come to your home for a home exam? So I'll give you just like 3 slides here on a home exam. So consent-wise, in the web, for a little tip for researchers, in wave 5, we put the consent at the end. We got 60% consent. This time we put the consent at the front. We got 70%. Okay, so that's something that we learned that usually consents were like an afterthought at the end. So this is something we did, that consents were higher. We also added a third category, consent yes, consent no, or I don't know, ask me later. And 17% of people said ask me later. So we call them the ongoing recruitment group. We're going back to those folks to say, hey, remember you said maybe on this? So we're trying to boost our consent rate by going back to them a couple more times to see. And between the yeses and the ongoing recruitment, we think we can get to our 75% consent goal toward the bottom, okay, for the home exam. That doesn't mean we can successfully visit all those people. Scheduling them is really hard. They need fasting, they work, FedEx doesn't deliver on Sundays to get their blood from their home in Hawaii to our lab in Vermont. There's all kinds of issues here in order to pull this off. So far with the 7,000 survey completes, about 5,000 have consented, and we've done about 3,000 home exams. And so we continue to try to schedule the ones who have consented to try to visit them. Sometimes the person isn't home, they schedule, stuff happens. So, trying to get as many completes out of the consents is what we're trying to do to get up to, of those who consent, we're trying to get to 75% completion rate there. We're at about 60%. So we'll continue to try to schedule and complete those exams. Weird things happen in the field. People have super high blood pressure. They have to stop the visit. We got 2 MDs on staff to advise what to do in those cases. There's dangerous neighborhoods people go to. It's like our FIs, like, oh, can't really do this. It's like, cool, stay safe. So there's this is a really difficult endeavor all over the country in order to pull off. So our field staff is doing an incredible job. In the little pilot sample 2, remember we had 145 people that were visited in person for 3 hours already. 92% of them consented to do a home exam. That's in-person consent is far higher than web consent. And then we just started those home exams. We've done 31 so far out of the 133 consents. So one thing I'm worried about here is with the 3-hour survey cognition visit, and even though they say yes, do they want us to come back to their home again with a different skill set with the phlebotomy and so forth? So we're worried about, even though if they consent yes, can we complete those visits? So we'll see how high we can get there. The kind of data we're collecting in the home exams, go back in AdHealth, we got a lot of anthropometric data, omics data. We've got GWAS on a large majority, a lot of gene environment work has been done in AdHealth, so we've got that data. A lot of immune infectious disease assays, including COVID-19 this time around, cardiovascular assays, metabolic. We collect medications data when we're in the home. We ask people to get their pill bottles and scan them in. We do renal and liver assays. We collect microbiome data that sits in a freezer until someone writes to us with a proposal to use it. And we're doing neurocognitive assays this time around as well because of the focus on cognition and early risk for Alzheimer's. Okay, beyond that, again, AdHealth is, our participants are in context. So we're continuing our contextual data collection. We've got teams of people with some additional R01s that are focusing on structural racism, structural sexism, heterosexism, xenophobia. Kara Joyner here at UTSA is the PI of the heterosexism work. She's in sociology here that's adding that data to AdHealth. And all of it to be linked to participants' home addresses over, going back 30 years. With the exposome supplement I mentioned above, we're adding a lot of natural, physical, and chemical environmental exposures to people in AdHealth, again, going back decades for sources like the EPA and so forth, linked to home addresses back to wave 1. And then administratively, this time we're collecting college transcript records for people who consent, and then birth records for people who consent. That is a state to like, hey, can we go get your birth certificate? You got to get IRBs from 50 states, and it's a royal pain. I think we're up to 5 right now because these states are really difficult to deal with, and increasingly so. But we're building a birth records database as well for all of our participants, and then mortality surveillance too. Okay, so in summary again, with this wave in AdHealth, we got survey data, 3/4 from the web, 1/4 in person roughly, a lot of cognitive, sensory, and physical functioning data, biological data, mortality surveillance, birth records, contextual data. ETA is 2025. We'll be in the field through 2024. It won't be January 1st. I think December 31st will be safer, but the data will be pushed out. Dozens and dozens of data sets here because all of these will be separate survey-based data sets, contextual, maybe hundreds of data sets be going out the door 2025 and into 2026. Okay, so ancillary studies as well. People can write to us with proposals to add data like Kara Joyner has done here at UTSA. It costs some money, or they can use our assays. We've got stored blood on a majority of the sample, so to test for whatever. But we review these like RO1s. We take them very seriously because they're using blood samples, so forth. And these data all become part of our archive. We go to lots of conferences to share our data. We haven't gone to APHA yet, but that's kind of on my list. It's expensive to do these things, but we're trying to get the word out that the data are available. For students in particular, we've got an AdHealth Users Conference every other year in June. The announcement will come out November 1st. Students can anybody can submit an abstract by February 29th is our due date. I think 250 words. If it gets accepted, check a box to say you need funding. We've got funding to support students to come to the AdHealth Users Conference. It's in Chapel Hill at beautiful Rizzo Center. I took that photo on the right during COVID. I said, what's the Rizzo Center? I drove out there, and there was a vulture eating a snake right in front of the front door of the hotel. So I thought that was cool, so I put that on the, but aside from vultures and snakes, the Rizzo Center is a nice place to have a conference. And for people who want to learn how to use the data and talk about AdHealth for 2 days straight, this is the place to go. And then the access to the data. We've got public use data you can download in the next 20 minutes from ICPSR. Public use data, it's free. It's smaller, it's a little bit watered down compared to the restricted use data, which is through contract. And a faculty member needs to be the PI of the contract to get all the data you want going back to wave one in AdHealth. It's literally a treasure trove of data. Lots more to come. Obviously, hopefully we'll continue the study until the cohort gets old and beyond. So all that is available on our website. Just Google AdHealth, you'll find this stuff, and our staff are there to help. Get the data, use the data, and so forth. So that's all I got. We're fortunate to be funded by NIH. So thank you so much for your attention. Hopefully this was helpful.